Hello everybody, and welcome to another episode of Physiology Made Easy with me, Dr. Amir Sandhu. Now in today's episode we're going to talk about exercise prescription for patients who suffer with rheumatoid arthritis. Now the information is going to be particularly relevant to the patients themselves and also to healthcare practitioners who are involved in the care of rheumatoid arthritis patients. So that might be physiotherapists, exercise physiologists, or those involved in cardiac rehabilitation, and also those individuals that work with clinical populations in a community setting, so in gyms and phase 4 rehabilitation settings. So the purpose of today's presentation is really to give you an overview of the pathophysiology of rheumatoid arthritis, so what it is and how it affects the joint and also the blood vessels to cause cardiovascular disease. We'll look at some of the scientific benefits of exercise interventions in rheumatoid arthritis patients, so I've abbreviated rheumatoid arthritis as RA, and also we'll look at some of the risks and how they can be mitigated when you come to program an exercise plan or prescription for these patients. We'll also look at the key components that you would put together in an exercise intervention. So we'll look at aerobic resistance, flexibility, and some ways that you can address some barriers to exercise. Now, rheumatoid arthritis is a chronic inflammatory disease, and it's a systemic disease, which means that it affects pretty much the entire body. So it's an autoimmune condition. We don't necessarily know what causes rheumatoid arthritis, although there are several factors that might trigger the body to start attacking its own tissue. And in the case of rheumatoid arthritis, it's the tissue that's in the joint. And what happens with rheumatoid arthritis is that the inflammation that happens inside the joints will eventually wear the joint away, the cartilage, and will start to cause bone erosion after a certain amount of time. So it's a condition which is quite severe. It affects about 0.9% of the population in the UK. It's more common in females, so there's a 3-to-1 ratio compared to males. So that's some of the things that you have to think about when looking at the disease. It's characterized by pain, swelling and stiffness of the joints. Okay, so what happens with the symptoms is that they can start off very gentle or they can be severe, so it varies from person to person, but the kind of cardinal signs of inflammation are present in most patients that present with rheumatoid arthritis, and the stiffness can actually be quite debilitating. So the pain is one thing, but not being able to move freely, it affects activities of daily living and quality of life as well. Now, if the rheumatoid arthritis is not managed effectively, so if the patient is not put onto a right combination of anti-inflammatory medication, then over time you can get joint destruction and deformity. And what we can see in the pictures here is kind of like an illustrative X-ray showing deformation and damage and erosion to the bones in the hand, and we can see that kind of visually here as well. Now, a hand that's deformed like this is not going to be able to carry out functional tasks like opening a jar, a bottle of milk, or a car door handle or door handles in general. So it is really going to affect that patient quite significantly. Now, as if things couldn't get any worse, rheumatoid arthritis patients also have an increased risk of cardiovascular disease. Now, the reason why that might be is that some of the inflammatory cells that are happening or that are kind of proliferating inside the joint are also the same inflammatory cells that we find in an atherosclerotic blood vessel. So there is a hypothesis that the inflammation might cause direct injury to the blood vessel, or it might alter other metabolic factors, so like cardiovascular risk factors, high blood pressure, high cholesterol, glucose regulation, and that may in turn cause damage to the blood vessel. But this picture is more detailed than the one on the previous slide, and what you can actually see is that there are numerous changes that are happening inside the joint, and you can see, for example, these pro-inflammatory cytokines, tumor necrosis factor alpha, interleukin 1, we've got interleukin 6. These are all involved in propagating inflammation inside the joint, and they start to form this very thick tissue called pannus in the joint, and that eventually starts to lead to the destruction of joints because it's involved through a series of biochemical reactions of the activation of osteoclasts, and osteoclasts are involved in bone erosion. Okay, now TNF-alpha, interleukin-1, interleukin-6 are also, as I said, are found inside the vessel. So, you know, with where for example, you've got white blood cells like the mast cells, they will be releasing TNF-alpha, interleukin-6. You've got some of the other immune cells like the macrophages, which normally engulf foreign bodies. They'll be secreting cytokines into the blood vessel, and obviously over time you get lipid deposition, narrowing of the vessel, and that increases the risk of developing a heart attack or stroke. So we can see that there's lots of similarities between the joint and the blood vessel, and certainly in scientific studies that have been carried out in populations of rheumatoid arthritis patients, we've been able to observe you know, quite a high risk for cardiac events. So this meta-analysis was conducted by Vina Zubieta and published in 2012, and it looked at approximately 41,500 patients from these 14 observational studies, and what they found was that there was a 48% increased risk for a cardiac event, and the risk for the most severe cardiac event, which is a myocardial infarction or heart attack, was 68%. Okay. Also, rheumatoid arthritis patients at the point of diagnosis are 3 times more likely to have had a previous myocardial infarction. Okay, and this kind of links in with a Danish study which was conducted in 10,000 individuals that had rheumatoid arthritis, and what they found was that the myocardial infarction risk in RA patients was actually similar to non-RA patients who were 10 years older. So that tells us that there must be some degree of acceleration of the damage inside the blood vessel in patients with rheumatoid arthritis. So there's this vascular aging that might be occurring that puts these patients at a greater risk of a heart attack. So in terms of death in rheumatoid arthritis, now rheumatoid arthritis patients do not die from the symptoms of their joint. They normally die from a cardiac event, and it's usually a heart attack. So cardiovascular disease mortality in rheumatoid arthritis has also been studied via a meta-analysis conducted back in 2008, again by Vina Zubieta and colleagues. And what they actually showed was that when they looked at all of the studies looking at cardiovascular disease mortality, that's 24 studies consisting of 111,758 patients, they were able to show that there was a 50% increased risk of cardiovascular disease, and they used what's called the standardized mortality ratio. Now, this basically looks at the number of deaths that were observed in the population of interest, so in this case rheumatoid arthritis, and it compares those observed deaths with the expected deaths from the general population, so people that don't have RA but that are of a similar age and similar sex to RA. So they found that when doing this comparison for CVD events, they actually showed that there was a 50% greater risk of having a cardiac or dying from a cardiac event in RA when compared to age and sex matched general population. So this is obviously quite an important finding, because it helps us as healthcare professionals but also as patients to know about the main factors that might be causing a decline in health and poor prognosis. Now, with rheumatoid arthritis, it's a condition which is characterized by pain, as I said before, and the stiffness, and you have you know, quite severe inflammation in the joints, and sometimes those joints need to be replaced. That's how severe it is. So it's not surprising that approximately 68% of RA patients are physically inactive, so they don't do any physical activity whatsoever. Yet we know that physical activity for the general population is actually good for helping people that have chronic diseases. So if they're not physically active, then it's not surprising that their aerobic fitness levels are going to be lower, and their strength levels are also going to be lower when compared to the general population. So here we have a population that really needs the kind of targeted intervention of exercise, but yet they're not able to access that, or they're not able to get that, and so consequently they have these reductions in actual variables that affect their quality of life. And if you have poor aerobic fitness and you have poor strength, then it's going to be difficult to climb stairs, get in and out of cars, and really do those activities of daily living. They become progressively worse. So the idea of incorporating physical activity in the treatment plan for a patient is to try to help them have some degree of normality in their day-to-day life and to have good long-term prognosis of the condition. Now, in terms of, before you prescribe exercise, you want to be able to believe that it works, and to be able to do that you need to have the science to back that up. And this is actually a study done from my colleagues, Professor George Metzius and Dr. Antonia Stavropoulos-Skolinoglu. It was a study that I was actually involved in Dudley, which is one of the world's most prestigious rheumatology centres, and we looked at whether supervised exercise can result in an improvement in cardiovascular disease risk and also rheumatoid arthritis disease severity and activity. So we recruited 36 rheumatoid arthritis patients, and they were randomly allocated to either a 6-month supervised exercise program or a control group where they would just be given telephone advice about exercise and healthy living. Okay, so these patients were in this program for 6 months, and we were doing these measures of blood vessel health in the small vessels and in the large vessels, and we took some baseline measurements as you do before you start an intervention, and we repeated those measures again at 3 months and 6 months. And what we found was that in the group that was having the supervised exercise, according to current guidelines, they had significantly improved perfusion in their microvessels at 3 months and at 6 months. Similarly, in their large vessels, there was an improvement in their blood vessel function of the brachial artery in the arm at 3 months and 6 months. So this was indicating that, as expected, exercise would have a positive effect in rheumatoid arthritis patients. Even if they may have compromised blood vessel health, there is this potential to improve the status of the blood vessels. Now, in terms of risk factors, which are very prevalent in rheumatoid arthritis, and we don't really have time to go into those, but they are, lots of RA patients will suffer from high blood pressure, approximately 70%. They'll also have high lipid levels as well. And again, from this study, we were able to see that at 3 months and 6 months, there was a significant reduction in systolic blood pressure. There was a reduction in triglycerides at 6 months, which is as expected. It always takes changes in lipids a little bit longer following aerobic exercise. And what was also nice as well is VO2 max is a measure of fitness, basically. It's a gold standard measure of fitness, and we were able to show that these patients who had very poor fitness compared to the general population, these patients were able to quite dramatically improve their aerobic fitness at 3 months and 6 months. So that was quite reassuring for us that you get patients onto a program and they will respond, and that will manifest in terms of improvements clinically as well. Importantly for the rheumatologist, disease activity, which is a measure of how much inflammation a patient might have in their joints and their body at a given time, that was significantly reduced at all time points in the exercise group. So there was definitely something going on with exercise having this positive benefit. So we know that exercise works. Since the studies that we performed back in 2013, there's been more studies that have been published since, and they support the notion that exercise is safe and it's beneficial to patients with RA for their disease symptoms and also for lowering their cardiovascular risk. So as a practitioner and also as a patient, what do you need to do to be able to get the benefits of exercise? Well, in terms of aerobic exercise, what you really need to do is focus on doing 3 to 5 days per week, okay? And the reason why there is a range is because if you're a patient who's never exercised before, you want to start at the lower end of this range. So, at the very beginning, you want to be doing not that many days per week, perhaps 2 to 3 days as you start to get used to the movements and what the body experiences. But with time, as the weeks progress, then you would increase the frequency of how much exercise you're doing per week. Now, the guidelines from the UK government for physical activity is currently 150 minutes of moderate intensity physical activity, or you do 75 minutes of vigorous intensity activity, or you can do a combination of both. Now, that recommendation is also relevant to rheumatoid arthritis patients. So rheumatoid arthritis patients can choose a duration which matches this. And remember, we're talking about per week, so this doesn't equate to that many minutes per day. So that's what the recommendations are in terms of the duration. Then the intensity. So it's very important when you're starting off that you start at a very low intensity, perhaps lower than the moderate that's listed here. So there are ways that we can measure somebody's aerobic fitness, and one of the ways from the aerobic fitness test we can actually calculate the heart rate reserve. So we can use that to set the intensity, and we can set the intensity between 40% and then progress it up to 60% and higher as the patient starts to have the adaptations taking place in their body. Now, in terms of the type of exercise, lots of research has actually been done in RA patients, and the standard stuff like walking, cycling is fantastic. Aquatherapy has also been shown to be beneficial in RA patients because you're in an environment where the buoyancy of the water supports the joints. There's nice light resistance as well, so you're getting a cardiovascular / resistance workout. Cross training is also very effective, and this is an interesting one. There is research coming out that dance can be very aerobically beneficial exercise, and again in RA patients where they might struggle for motivation, engaging them in things that they like to do is much better than saying, right, I want you to walk 30 minutes a day, 5 days per week. That might not be as motivating for some people. So there are alternative activities, and the research supports that, and you've just got to be able to think outside the box, work with the patient, and also the patient needs to think about themselves in terms of what they enjoy and what they could incorporate into their routine. The good thing is, in terms of the physiological benefits of aerobic exercise, if you start taking part in aerobic exercise and you stick with it, you will get what we call angiogenesis. So you'll get more networking of blood vessels. New blood vessels will start to be created, and what that means is that when your heart pumps, you'll get more of that blood to all of the tissues in your body, which means better perfusion or oxygenation of that tissue. That basically means you're less likely to suffer from fatigue. And fatigue is a major symptom of rheumatoid arthritis because there's so many things going on inside the body with the inflammation. Sometimes it's difficult for patients to even function through the day because there's so much tiredness going on. So aerobic fitness will improve, the enhanced blood vessel will improve aerobic fitness, improve blood supply, and hopefully help to reduce symptoms of fatigue. And of course, importantly, they will improve functional capacity. So those activities of daily living that we talked about earlier, they will become easier when you have better aerobic fitness. So moving on to resistance training, so exercise prescription in RA, it's not too difficult, 2 to 3 days per week. It's very similar to what you might do with individuals from the general population. We're looking at 60 to 80% of 1 repetition max. So again, if you're a practitioner, you'd want to get the patient in and do some baseline assessments to begin with. You'll work out what their 1 repetition max is for different, for upper body, lower body, different exercises, etc. And then you'd set that intensity low to begin with, and then you'd use this window here to progress as the adaptations take place. Now, in those individuals that have never done resistance training, their entire life, you can start at a lower intensity, so you can go down to 50% or 40%. As the patient feels comfortable, you can start to increase and work your way up to there. So everybody will have a different starting point. It's the job of the practitioner to gauge where the patient's at, work with them to feel what's comfortable and what will be enough for them to start having adaptations taking place. In terms of what you can do, well, with resistance training, it's actually quite a good choice because you can use machines that are available in a gym, you can use free weights, you can use TheraBands, you can do body weight exercises. There's lots of different things that you can actually do. I've put body part split here so that you don't exercise everything all in one go, although that's not necessarily a problem if you want to do that, but you can split body parts like chest and tricep, shoulder and biceps, legs on a separate day, back on a separate day, so you can actually do things to suit in that respect. Equally, you can mix resistance exercises with aerobic exercises and make a circuit session. So there are various iterations of a program that you could use. In terms of the advice from the literature, each exercise should be performed for about 8 to 12 repetitions because that promotes improvements in muscle hypertrophy and therefore an increase in strength. And you should aim for somewhere between 2 to 4 sets. Now, these sets here don't include the warm-up sets. So, what you want to do when you start resistance training is have some sets with a very light weight just to warm the muscle, warm the joint, warm the body. And then once you're happy and you're warm, that's when you start the actual training phase so that the adaptations can take place. And this is very common that some patients can either have no access to the gym for financial reasons or because they don't live close to a gym and travel is a problem, or they feel conscious about going to a gym. It might be that they have a consciousness about how their body is, and if they've got any deformities, that might be something that can put people off from going to the gym. So you've then got to consider home-based exercise. Okay, and there you can use body weight exercises, you can use therabands. So there's certain things that you can do at home so that the patient still has the benefits of exercise. And indeed, if gym access is an issue if it's in terms of finance and not being able to get to it, but if it's a case of a person feels self-conscious, then it's a good idea to actually create a class which is specific for rheumatoid arthritis patients. So you block off a part of the gym or a room which is for RA patients, and it increases that social gathering and kind of enhances that intrinsic motivation as well. Now, following this program here, it has been shown by this paper back in 2001 by Häkkinen et al. To elicit strength gains of about 20 to 60% and also reductions in disease activity, disease severity and pain as well. So resistance training has these benefits that are tangible for the patient. In terms of what happens physiologically then, if we take, for example, the knee joint, so knees can be affected in rheumatoid arthritis patients. One of the things that will happen with resistance training is that you'll start to get hypertrophy, myofibrillar hypertrophy of the muscle fibers. So they'll increase in their cross-sectional area, which basically means that they can produce more force, okay, and they reduce some of the tension that goes through the joint because the tendons will also become stronger and thicker, which we'll talk about in a moment. So when you have a stronger muscle, it helps to protect and support the joint, and that reduces the load that goes through the joint. It also helps to stabilize. A strong muscle will stabilize a joint as well. So that's some of the benefits that you would have from doing resistance training in the muscle. Obviously, in terms of activities of daily living, so if we look at the rectus femoris muscle here, then you train that. Stair climbing is going to be easier. Getting in and out of chairs is going to be easier. If we look at the upper body, then carrying your shopping, opening jars, and doing all those other types of activities become so much more easier. Now, tendons and ligaments, extremely important. When you do resistance training, essentially what happens is the force that's produced by the muscle is transmitted through to the bone via the tendon. So when you do resistance training, as the force transmits through the tendon becomes thicker. There's more collagen fibers that are deposited into the tendon. It becomes thicker, stronger. It stabilizes the joint. It's less likely for the joint to have any kind of like destabilizing issues, and it helps to reduce inflammation as well. And similarly with the ligaments as well. So they become stronger, they become thicker and stronger. I mentioned this term earlier, osteoclasts. Now, osteoclasts are these cells which are involved in the resorption of bone, or to put it into another term, dissolving the bone. Okay, so osteoclasts, you don't want osteoclast activity to be high. Thankfully, exercise, particularly resistance training, helps to reduce osteoclast activity, and some studies show promote osteoblast activity, which helps in bone deposition. But certainly if you've got an older patient, and particularly females are susceptible to increased osteoclast activity, because after the menopause, when estrogen levels become low, osteoclast levels start to go up, because estrogen inhibits or suppresses osteoclast activity. So as soon as you have a female that goes through the menopause, loses estrogen, the protective effects of estrogen, osteoclast activity will increase. So by doing resistance exercise, you're helping to counter some of the negative effects of menopause on bone health and on the joint. Now, it's very important not to forget flexibility. So we've had aerobic training, we've had resistance training. Along with that, when your body is warm, it's important to make sure that in the warm-up phase and also the cool-down phase, you're doing daily flexibility exercises to try and increase the range of motion, okay? It's nothing too taxing. You can do arm rotations, arm swings, start off just doing your general kind of major movements for about 10 reps, and then once the body's nice and warm, you can do static stretching. So this is, you know, what you see people in the gym holding their elbow, trying to stretch their shoulders, triceps, chest. You can do those static stretching then when the body's nice and warm. This can be done at the warm-up, it can be done at the cool-down. Other ways to develop your flexibility can include going to yoga classes, Pilates, and any other kind of specific sessions which are geared towards improving flexibility. So that's up to the practitioner, it's up to the patient what they actually prefer. But indeed, it's very important to include flexibility in your program. Use the entire range of motion, try to feel that tightness in the muscle and the joint. It is highly individualized flexibility and varies from person to person. So you've got to do what feels comfortable for you. And the progression again is, you know, as you become more flexible, you can then obviously you know, stretch a little bit harder, and again that will depend from person to person. Now, both for the patient and for the practitioner, there are some special considerations for patients with rheumatoid arthritis that you need to think about when you're designing an exercise program. So the first is to avoid exercising inflamed joints. Now, in the old days, so we're talking 20 to 30 years ago, if a patient had active part of their rheumatoid arthritis, so they were in the active stage, the rheumatologist might say, you know, Mrs. Smith, I think you should rest for a couple of weeks until you're better, and then get back to some activities. That was the traditional approach. The modern approach, based on science, is that if you have inflammation, that doesn't mean that you should stop exercising and stop doing anything at all. What you should do is avoid exercising the inflamed joint, but exercise another part or carry on as much as you possibly can. So this advice about having bed rest is now quite outdated. So in this scenario here, you've got a patient who's got inflammation in the wrists and in the knuckles. So what you would try to do is avoid upper body exercise, focus on lower body exercise. You know, so you could do the cycling, and you could do TheraBand exercises with the legs, for example. So that's important, thinking about alternative exercises. And a patient might turn up to your class on that very morning and say, you know, my knees are feeling really bad. So at that point, you've got to have a plan B. So that should already be in place. And in that case, you'd consider, you know, doing upper body exercises. Avoid high impact activities or ballistic movements, rapid movements, okay, because those type of movements are not beneficial for patients with RA that have, you know, this susceptibility to inflammation in the joints. Gentle movements are better. Of course, when the patient is comfortable enough themselves and they progress to a level where they can do faster movements, that's fine. But to begin with, avoid ballistic type activities. Avoid heavy weights, especially above shoulder height. Now, the reason for that is because if you have somebody that's unaccustomed to doing resistance training and they lift a weight above their head, there is a risk that the weight could drop and hit them on their head, okay? So you want to avoid that situation. So you want to keep the weights above, towards shoulder height. Don't go higher. And it's better to have lower weight and go for higher repetitions because you want to build muscular endurance. You know, we're not talking about doing resistance training to, you know, enter a bodybuilding or powerlifting contest. We're talking about improving activities of daily living. So the next one is very important, and it's to inform your patients about delayed onset muscle soreness. Now this is something that you don't necessarily see in guidelines or in textbooks, but it's extremely important, perhaps the most important consideration. Now delayed onset muscle soreness can occur about 24 to 48 hours after exercise, and it can last up to 72 hours. Now if you've got a patient that, you know, with rheumatoid arthritis where it's characterized by pain, and they're leaving your session and then they go away, and over the next few days they experience that pain, that might be enough for them to never come back to your session again, because they might feel that the exercise has aggravated their rheumatoid arthritis. So you've got to explain to them that delayed onset muscle soreness is normal, it's part of the healing process of the muscle's getting stronger, and the pain will get less in subsequent weeks as your training adaptations take place. So just a simple little leaflet explaining what delayed onset muscle soreness is extremely important. Another thing that you can do is incorporate activities of daily living. So, you know, getting in and out of a chair or stair climbing, extremely important, and they're easy wins, because if you can get the patient to do these type of activities as part of the session, then they will be able to have the tangible improvement, and it will improve their motivation. They'll be able to see something that can benefit them straight away when they go home, and it will increase their kind of enthusiasm to continue with the program. So do incorporate these activities of daily living, because they often have a very quick impact in terms of improving functional ability. So the take-home messages from today's presentation is that rheumatoid arthritis patients can perform regular exercise, which can lead to a better prognosis, especially in relation to the cardiovascular disease risk. So we know the patients die from cardiovascular disease, so there's a definite win there. We know that exercise is medicine, so it's an effective treatment to reduce hospital admissions and GP appointments, which is going to reduce burden on the healthcare system. There's going to be a better improvement, or, you know, enhanced quality of life in these patients, because they'll be able to do the things that they love doing, picking up their grandchildren, going for a walk, and those type of activities. There are barriers, and there's, you know, several barriers that need to be considered in terms of exercise programming and adherence. But again, working collectively as part of a team of professionals with a similar interest, similar vision, will enable in your locality to have a rehabilitation program which will be beneficial to patients in the local community. So that's all we've got time for today. Thank you very much for joining me in this episode. Hopefully I'll see you on another episode where we'll talk more about exercise programming for another chronic condition. I'll see you soon.